So the topic I'm coming is AV septal defects, and I'm very grateful to the introduction by Julia. Before all the genetics, I don't need to recapitulate because it has been explained. And she also, how the primum ASDs and the inlet VSDs look like, you know already. So makes my talk much easier. I would like to remind you that there are synonyms that are being used if we talk about AV septal defects. Some people talk about AV canal defect or endocardial cushion defect. It's the same. It's a common abnormality to have an AVSD. Is 5% of all structural heart diseases are AVSDs in all variants. It's also very important that it is very often associated with genetic abnormalities, unlike the muscular VSDs that you just heard have almost no risk of a genetic abnormality, and even the perimembranous, the risk is low, unless you have a overwriting aorta and the tetralogy. So let's first look at the normal AV junction and then go into the anatomical and diagnostic features of AVSDs and the associated abnormalities. As you have heard and seen before, is that the atrioventricular septum should have only one communication really, and that's the patent foramen ovale. You have two separate inlets to both ventricles. The tricuspid valve is a bit more apical compared to the mitral valve. If you look en face in the surgical view, the right AV valve has a septal leaflet, posterior inferior leaflet, and the anterior superior leaflet, while the mitral valve has an anterior leaflet and the posterior mural leaflet. Both valves are separated by, both valves are surrounded by a fibromuscular ring and are completely separated from each other. Finally, the aorta itself is wedged in between the AV valves. So they are in continuity. The mitral valve is in continuity with the aortic valve. This is just the way the valve opens. Now, one thing we always talk about when we look at the four-chamber view is the heart axis, the size of the heart, but we always never mention the relationship between atrial septal length and ventricular septal length. And that's quite a distinct feature that you can use that will help you with the diagnosis of AVSDs because it's not normal. I will show this in a moment. So classic, you have an inlet and an outlet ratio that's about equal. The atrial length is much shorter than the ventricular length, and it's usually about half. So about 50% of the whole let's say differently, the ventricular septum is about twice the length of the atrial septum. That's a normal relationship. And this has been shown in papers and where people try to look the difference between AVSDs and the controls, the normal. So about 50% is the length of a septal, of the atrial to ventricular length ratio. Now, the essential features of all AVSDs is, first of all, there's a common AV valve that spans over both ventricles. There's a variable septation defect in the center, and the aorta becomes unwedged, and the outflow tract is elongated. And this is shown here. So with AVSDs, the ventricular septum is scooped out, so it becomes shorter. So the inlet portion is shorter compared to the outlet portion, and it reaches about only 70% on average. And this is irrespective if there's a partial AVSD or a complete AVSD with a big inlet VSD. This is, again, the same pattern shown. And The partial AVSDs can sometimes be quite tricky to diagnose because you don't necessarily see a communication. In the worst case, even, you don't have any communication at all. It's still a partial AVSD. So this is an example of a patient with a partial AVSD, where you see the relationship between the atrial septum and the ventricular septum are about equal. And this is again shown in this paper published some years ago in Ultrasound Obstetrics. Another feature, because of the elongated outflow tract, is that the aorta is higher up. It's an elongated outlet. The outlet part is not just the aspect of the ventricular septum, but it's also the anterior, the bridging leaflet, the superior bridging leaflet that forms part of the outflow tract suddenly because of this abnormality. And as a result, you see that the aorta is not wedged between these two AV valves, but becomes unwedged. It's not in between the common AV valve or a partial AV valve. And this is shown in this pathology specimen, nicely shown, a normal heart with the aorta in the usual position, and here a common AV valve with one annulus, a single orifice, so it's a complete AVSD, but the aorta is unwedged. It's not at the normal position. When we look at AVSDs, first of all, we would like now to understand more the anatomical variations. Is this a common versus separate AV valve or orifice? I told it's a common AV valve, yes, but you can have two orifices or you can have a common orifice. Then we would like to know more about the level of the shunting. Is it atrioventricular? Is it only atrioventricular? Or in the rare cases you can have no shunt and is still an AVSD. And then, very important for counseling, what is the ventricular dominance? Is this balanced or unbalanced? We often talk about different variations, anatomical, and talk about complete AVSD, intermediate AVSD, transitional AVSD, and partial AVSD. I think for fetal echo, it's not really important. What you need to know is this a common AV valve, or with a common orifice, or is this a common AV valve with separate orifices? You would need to know if there's a large ASD or large VSD, like in the intermediate AVSD as well, even if you have two orifices, or do you have a large ASD and a small or no VSD, because that defines what happens after birth in terms of surgical planning and also the repair you have to do. These lesions here, they require relatively early after delivery surgery because you have to close the communications. So usually the surgeries are done between 2 and 4 months of life, while you can wait in this condition to do the repair to 2 to 4 years of life. So quite important for us with counseling to look where the communication is and how significant this will be after birth. Now, with the complete AVSD, as with the partial AVSD, we have an abnormal AV valve. It consists of 5 leaflets with 2 bridging leaflets, which are shown here, superior and inferior. The mural leaflet is no more where it was. Usually it goes this way, but it's really more lateral. And the anterior superior leaflet can be the right anterior superior leaflet can be variably small. It can actually be even fused with the superior bridging leaflet, and you have a right inferior leaflet. There is no communication between the superior bridging leaflet and the inferior bridging leaflet in the complete AVSD. So you have septal defects between the atrium and the ventricle. We often talk also about Rastelli classification, which frankly in the fetus I don't really care about. But for the sake of completeness, this is the most common form, is the Rastelli type A, where you have attachment of the superior bridging leaflet to the crest of the interventricular septum, the most common form. It's also one that explains why shunting at ventricle level can actually be less in this patient group, and the Rastelli type A potentially can even close VSDs, inlet VSDs before birth if they are smaller. This is extremely rare. This goes to an accessory papillary muscle, and this is the type C, where you have a free-floating superior bridging leaflet without any attachment to the ventricle septum. The only thing why I would be interested in looking at this in more detail, this is most commonly associated with trisomy 21. So it helps you a little bit with counseling. Now, the partial AVSD is a common AV valve with 2 orifices. And the superior bridging leaflet is usually attached in the most common form with the primum ASD to the crest of the ventricle septum. And then you have a bridge between the two, the superior and the inferior leaflets, so they're fused partially. And you get 2 orifices. This area here is what is called cleft. It's not really a cleft. It is just the opening between the anterior and the superior and the inferior bridging leaflet. But as you can look, if you look at the left AV valve, this is no more a bicuspid valve. It's now functionally a trileaflet valve. And even if you do surgery and separate this, this will be a trifolite valve, not a normal valve. The right AV valve here too has 3 leaflets if you separate this. Now, I mentioned this briefly, the ASD classification. The main difference between the complete and the rest of the other forms AVSD is that you have a large primum ASD and inlet VSD with a common AV valve with a single orifice. Everything else has 2 orifices. Let's look at some examples. This is a fetus with trisomy 21, and you can actually see the attachment of this AV valve to the crest of the ventricular septum. So Rastelli type A. It's clearly a common AVSD, and it's balanced. Interesting in genetic abnormalities, the AVSDs are usually the best to repair, and the ones that don't have genetic abnormalities very often have unbalanced AVSD, that are more difficult to treat or not at all with a BIV outcome. What you also can look at in the en face view, you see how the AV valve is overriding and the outflow tract is unobstructed. If it's trisomy 21, there's not uncommonly an association also with tetralogy of Fallot, where you can see a narrowing of the outflow tract. This is a nice outflow tract. More images of this, so nice pulmonary artery, and the aortic arch looks okay. This is the case I mentioned before, and it's easy to overlook that this is abnormal. But first of all, the AV valves appear to be on the same level, which brought us the suspicion. And as I mentioned already, the atrial and ventricular septal length is about equal. But to prove that this is really a patient with that has an AVSD might be more difficult. And in the short axis is not the best quality, but you see that there is actually a septal defect shown. And another thing that we always look is try to find the papillary muscle. And this papillary muscle has an orientation that is different from the normal. It is superior, inferior, while normally it's oblique. So looking at the papillary muscle might also help you, because the whole left AV valve orientation is different. The papillary muscle actually are not in the normal position. This is the same fetus, and what you can see, there is some malalignment of the atrial septum that we did not see before. There is actually an atrial communication that we don't really see in utero, and part of the communication between both ventricles is closed due to the attachments of this Rastelli type A valve. Now, this is the flow pattern, small atrial communication, that no wonder we didn't see, and the VSD is even smaller. If you look at atrial septum and ventricular septum, try to look from the side, perpendicular. Don't try to look anterior, posterior, because you will always have some dropout. It's the right plane to look is perpendicular to the septum, and then you can see the septal defects. Here is one we see in atrial communication. The ventricular communication has closed, and this has been reported by others. That is most likely if the VSD component is small and it's Rastelli type A, that after birth you might not see really a ventricular septal defect. But this is anyway not a group of patients you would intervene early after delivery. This is a group of patients you do surgeries usually at several years of life. Anatomical risk factors that are predictive of outcome is the ventricular hypoplasia. So if you have an unbalanced AVSD, malalignment of the atrial and ventricular septum, left ventricular outflow tract obstruction, and additional left AV valve pathology, which are rare, double orifice, left AV valve, parachute valve, which can be very important for the repair. So look, if you see two papillary muscle or only one on the left side, then a high origin of papillary muscle with short cords can cause obstruction and dysplastic valves. And then the association with heterotaxy, which I will not cover in this talk, but I have another one on the last day. And AV valve, AV septal defects are a common feature of heterotaxy. So ventricular dominance and AV septal alignment. Here are some illustrations how this can look like. A dominant right ventricle with a small left ventricle, quite unlikely that you get a bi-V outcome if it's severe. And a single ventricle with an AVSD is not a good prognosis, because these valves tend to fail later in life. A balanced type, and here an unbalanced with a left dominant ventricle. Now, what helps you in this situation too is look at the short axis view. What is the contribution of the AV valve in terms of flow towards the right and the left ventricle? This is an example I show initially, and everybody will probably see this immediately after talk about pulmonary vein abnormalities. It's a trisomy 21 child that has actually a double bubble, so it's a duodenal obstruction, and it is not an abnormal pulmonary vein or an ascicus vein. It's simply an obstructed gut. Balanced ventricle, normal flow. And what you can use in this situation, with you have the en face view, you can use 3D reconstruction, and then you can actually get some nice images that tells you how the AV valve functions if you have time. This is for me more a toy here, because obviously it looks quite nice and balanced. This looks less nice. So what you have is a small left ventricle, a good sized right ventricle, and you see the dominant inflow clearly goes towards the right ventricle. And if you want, you have a double inlet into the right ventricle based on the deviated ventricular septum. Short axis view again can help. And if I draw the line here, this is in diastole, and we trace this, you will see that clearly the left AV valve component is much smaller than the right. If there is a cutoff, really, you can say this is never a single ventricle, will be difficult. I think this was also parachute left AV valve, so we ended up with a a single ventricle repair. This is the left ventricle outflow tract, and this, which looks okay, but this fetus also had a coarctation of the aorta. So if you have small left-sided structure, always look if there's some explanation for or some consequences of the abnormal flow. Here a dominant one on the left ventricle is dominant. The right gets almost no flow compared to the left ventricle. Again, in the short axis view, or this four-chamber view, you see that there are some attachment of the common AV valve to the crest of the ventricle septum, but there's clearly a very small right ventricle. Every time you have an unbalanced AVSD, you need to be absolutely sure that this is not a heterotaxy case. Here, just illustrating a nice IVC flow going back. Doesn't exclude the right isomerism yet, but it's very important that you have a clear anatomy. Now, if you look here, small ventricle more superior with good outlet into an aorta, and posterior the pulmonary arteries, so normally related great arteries, which is again important to rule out and be with counseling. But these are not patients we usually achieve by IV outcomes. Another example of a very small left ventricle compared to the right ventricle, and you see the left ventricle outflow tract is small compared to the pulmonary artery. So mechanisms of the left ventricle outflow tract. I mentioned this. This is the scooped out ventricle septum, and the outflow tract gets elongated and can be narrowed also because of this bridging leaflet, which can have abnormal attachment. But there are other things that can cause it apart from abnormal aortic valve, like membranes, muscle bundles, tissue tags, and it's not unusual to have left ventricle outflow tract obstruction, which is one of the very worrisome things we see. We have right now one patient that just had an AVSD that lost completely flow into the aorta thanks to an abnormal anterior superior bridging leaflet, and functioned like a double-outlet right ventricle, but no communication between the left ventricle to the aorta, only way out or remote VSDs. So patient we can't fix with an anatomical correction. Another concern are AV valve regurgitations, in particular if you have unbalanced AVSDs, because they are single ventricles. And if you start up already with a severe in utero regurgitation, you almost certainly will not get away with a single ventricle repair. This is a balanced, relatively balanced ventricle with severe regurgitation. After birth, this reduced, fortunately, and didn't cause us any big problem. And both openings to both ventricles is quite reasonable, so balanced AVSD. What happens with AV valve regurgitation that you see in utero has been examined. In 89% is unchanged, so if it's severe before birth, it will stay severe after birth. But in 22% it can actually increase and get worse. And many of us who follow single ventricles know that AV valve regurgitation is a problem and typically progressive in single ventricle physiology. Then trisomy 21 and heterotaxy were not risk factors in this paper, which is a bit surprising. So their conclusion was that the AV valve regurgitation in utero is predictive of postnatal AV valve regurgitation in most cases. A final word to AVSDs and association with genetics. Trisomy 21, 45% of children with trisomy 21 have structural heart disease, and half of all patients with complete AVSDs do have trisomy 21, so it's strongly recommended to genetic testing. is usually associated not with other intracardiac abnormalities, so the AVSD is isolated. If it's tetralogy of Fallot, you can bet it's trisomy 21. It's rare that you see this combination without being trisomy 21. They're usually not dysplastic, the valves. It's more likely to have a dysplastic AV valve if the child has no known genetic abnormalities, strangely, which can affect also the outcome. Then associated abnormalities, other abnormalities, so 50-60% of fetal cases, we will find something else. Most frequently left-sided obstructive lesions, which I explained to you a little bit the reason why, the elongated outflow tract. Tetralogy of Fallot, I mentioned heterotaxy, is in 35%. If we have an AVSD, we will find heterotaxy as the underlying cause, so also very important to make your situs assessment properly and see what sort of associated lesions you have. Then non-karyotypic extracardiac abnormalities are also relatively common. Finally, a word to the repair. It's not a cure, as you know. This patient needs lifelong follow-up. They have substantial risk of requiring surgeries later in life. Termination of pregnancy in the fetal series, that's the UK. So UK has traditionally high termination rates, but it's not different from Canada. So termination of pregnancy, 60% of patients will decide after diagnosis of an AVSD to terminate the pregnancy. But the survival for continued pregnancies is usually good to birth. Perioperative mortality is low. I would think it's probably less than 2% at our center. The survival after surgery is about 85% to 10 years and about 70% to 30 years. So it's certainly a reduced lifespan. Reoperations 10 to 15%. Left AV valve regurgitation is one of the major problems we have. And sometimes we have to replace left AV valves already in young children and have to put in valves that are not necessarily made for that purpose. Then left ventricular outflow tract obstruction is something you have to follow for, and visual shunts and coarctation is also a problem. So in summary, common denominators is deficient AV septum, common AV valve annulus with one or two orifices, associated syndromes, trisomy 21 heterotaxy, and the fetal echocardic approach. The for example, you look from the side, look perpendicular, don't look apex so straight off us on the heart, you might miss it. Visit the situs determination. If you have this, you need to be sure this is not a heterotaxy, and clarify the ventricular outflow tracts. Thank you.